Okay, so what I'm going to do is actually, I'm going to put my last lecture, which is the important lecture last, but I've got this timer here, so I can really look at the time and start my last lecture about 40 minutes before, but I'll finish what is in the program, because we had to give this hall for a wedding reception, for which you are not invited, by the way. At 5 o'clock I was told, so I will try to finish by 5 o'clock. Okay. So, at St. George's where I practiced, I took over as head of the department in 2001 and retired in 2013, but I slowly introduced the CTG master classes, and there are 4 people who do the lectures now: Dr. Edwin Chandraharan, Austin Ugumadu, Leonie Penna, Barry Whitlow, who has gone to another hospital. The idea is actually, it's not only good to teach people. Oh, this is not. Can you all hear me at the back? Yeah. So thank you, Jadip. So it's not only good to sit down and listen, because if I talk to you the whole of today, and when you go out and somebody shows you this is the case and this is a CTG, and what would you do? If you say, I don't know what to do, then my whole half a day is gone. So I always tell this joke. There was a boy and a girl, and the girl told the boy, see, I have taught my dog how to whistle. So the boy thought, that's fascinating. Let me try. And then said, dog, whistle. So the dog was just looking and wagging the tail. So he told the girl, what are you trying to do? Are you putting a joke or something? I said, listen. I said, I taught the dog. I didn't say the dog has learnt it. So that's the simple scenario. So whenever you go for lectures, if you don't test whether they have grasped the material, then it is of no value. So at St. George's, what I did was actually, we slowly introduced testing every midwife and doctor, including the consultant, to pass a test. You must get about 80%. Initially, I started with 8 questions, which is pathophysiology. You know, you must tell, are they late, are they variable, are they normal, abnormal, and so on. The second part was on pathophysiology. Tell me the pathophysiology behind this trace. Just 3 words or 4 words or 3 sentences. The third part is situational analysis and escalation. So I give you a clinical picture, show you the trace, and say, what are you going to do with this? If you're a midwife or a doctor, are you going to do a section? Are you going to do this or that? So I'm going to give you what we give in phase 3 of the test. So we asked them to define the trace using Dr. C. Bravado, which you might have heard, define the clinical risk, which I showed you about preterm, postterm, IUGR, meconium, etc. Describe the CTG features. What's the baseline rate, variability, decelerations, accelerations. Categorize the CTG as normal, suspicious, or pathological. Consider the underlying pathology and action. So if it is cord compression, what would you do? And 3 actions are common. Can we improve the condition of the baby by hydrating, putting her in a different position, etc. FBS, if you can't improve and still you're worried. And delivery is the third alternative. So I'm going to give you a clinical scenario, the CTG trace, and ask you to say what you're going to do with that clinical situation. And don't worry if you get it wrong or not. You are going to ask you to give the right answer. So this is an uncomplicated pregnancy. She's 41 weeks into her pregnancy. She's progressing normally. She's in the 2nd stage of labor. She's pushing. And the midwife who are listening to the heart rate soon after contraction, she tells, I can hear a deceleration, because in the 2nd stage or the 1st stage, you shouldn't hear a deceleration after a contraction. That means it is atypical variable or a late deceleration. So we had to put them on an electronic fetal monitor. So because she was worried, she puts her on the monitor, and the patient is still squatting and pushing. And this is the trace. She's pushing. You can see the pushing spikes. The baseline rate is steady. good variability, and there is a deceleration which is variable. I said with the head compression it can be variable, stays at the bottom for a long time and then comes out. So, but if you draw a line, occasionally you can hear the heart rate afterwards, but most of the time the heart rate is between the two vertical lines from the beginning to the end. So there is no rise in the baseline rate, there is no reduction in baseline rate, because those two means you have to intervene, either going up and up or coming down and down. Or if the interval between decelerations is getting shorter, then you have to intervene. So none of that is happening. So you know the pathology appears to be like a head compression. And the question is, what action would you like today? FBS, continue pushing, anticipate normal delivery. Forceps or vacuum, or if it is head is high, not favorable for instrumental, then do a section.